Welcome to this explainer. Grab your lab coats because today we're going on morning rounds. We're going to act as medical detectives, cracking 6 seriously complex clinical mysteries. And we're going to do it by connecting microscopic pathophysiology directly to life-saving management. You see, it's not just about memorizing a list of symptoms, it's about really understanding the underlying mechanisms that allow us to actually solve the case. So let's dive right in and see what we're up against today.
Here's our patient roster for today. We have 6 totally distinct cases to crack, ranging from cystic fibrosis all the way to acute gout. For every single one, we'll identify the mysterious symptoms, uncover the biological mechanism, and then reveal the pharmacological solution. Let's get started.
First up, Case 1, Cystic Fibrosis, or what we'll call the mucus mystery.
All right, picture this. Our first patient is a 17-year-old boy with cystic fibrosis. He has a stable, albeit low, BMI of 18.0, and genetic testing shows he has 2 F508del mutations. Now, despite being relatively stable in the past with daily chest physiotherapy, he is suddenly deteriorating with recurrent pulmonary exacerbations that require hospitalization. So we really have to ask ourselves, why are his supportive treatments no longer enough? Take dornase alfa, for example. It's an inhaled recombinant human DNase that works by cleaving extracellular DNA released by neutrophils in that infected mucus. It's a brilliant mechanical approach, right? By breaking down that DNA, it reduces mucus viscosity and helps clear the airways. But for this specific patient, just targeting the mucus downstream, it's simply not cutting it anymore.
The real solution here requires us to zoom in on his genetics. Because he's homozygous for that F508del mutation, the exact next step in his long-term management is initiating CFTR modulator therapy. We're talking about drugs like lumacaftor and ivacaftor, or even newer triple therapies. This is absolutely crucial. We aren't just putting a Band-Aid on the symptoms anymore. These drugs fundamentally improve the CFTR protein's folding and function, which enhances chloride transport right at the cellular level. It's a true disease-modifying therapy that slows down progression and can significantly extend survival.
Moving right along to Case 2, an immune system defect, which is perfectly described as the phagocyte failure.
When you have a patient presenting with recurrent skin abscesses, pneumonia, hepatosplenomegaly, and granulomatous inflammation, your diagnostic radar should immediately ping for chronic granulomatous disease, or CGD. The immediate management for a presentation like this is twofold. First, you admit the patient and start empiric broad-spectrum antibiotics, like trimethoprim sulfamethoxazole, to prevent a rapid clinical crash. Second, we need to actually confirm the diagnosis. So the key move here is ordering the DHR-123 test. This is a highly specific flow cytometry test that assesses the neutrophil oxidative burst by detecting reactive oxygen species. If you see diminished fluorescence, well, that confirms impaired activity.
But let's dig into why this actually happens. CGD is usually caused by a mutation, most often in the X-linked CYBB gene, which leads to a defective NADPH oxidase. What that means is the patient's phagocytes literally cannot generate the reactive oxygen species they need to kill off invaders. And this perfectly illustrates why specific catalase-positive organisms are so dangerous for these patients. We're talking about Staphylococcus aureus, Serratia marcescens, Burkholderia cepacia, and Nocardia. These tricky bugs produce an enzyme that degrades their own hydrogen peroxide, which completely prevents the patient's already compromised phagocytes from using the bacteria's own weapons against them.
Let's look at Case 3, Osteogenesis Imperfecta, or fragile foundations.
For a child suffering from frequent fractures and skeletal deformities, which are the classic hallmark clues of moderate to severe osteogenesis imperfecta, we can't just fix the broken bones and call it a day. We have to fundamentally change the bone remodeling process itself. We manage this by initiating bisphosphonate therapy like pamidronate or zoledronate super early in childhood. These agents work their magic by specifically inhibiting osteoclast-mediated bone resorption. By essentially hitting the brakes on the cells that break down bone, we increase bone mineral density and drastically reduce the incidence of future fractures. It's an intervention that directly modifies the course of the disease, helping these kids maintain their ambulation and functional mobility.
Now for a high-stakes emergency in Case 4, aspirin overdose, known as the acid-base shift. Listen, aspirin toxicity isn't just a straightforward poisoning. It creates a very specific, incredibly dangerous two-phased mixed acid-base disorder that you have to decode fast. In Phase 1, which is the first 20 minutes, the aspirin directly stimulates the respiratory centers in the brainstem. The patient starts hyperventilating, blowing off tons of CO2, which drives their pH up, creating an acute respiratory alkalosis. Because it happens so quickly, the bicarbonate levels stay normal. But then we hit Phase 2.
At around 12 to 24 hours, the intrinsic acidity of the aspirin, which is salicylic acid, really starts to accumulate. This massive acid load drops the bicarbonate directly, shifting the patient into a primary metabolic acidosis, which drags the pH down even though the patient is still hyperventilating.
This massive accumulation of acidic metabolites drives what we call a high anion gap metabolic acidosis. Typically, you're going to see an anion gap well above 13. And here is a crucial takeaway for you. In salicylicate toxicity, the sodium and potassium levels are usually completely normal. The salicylates represent the classic S in the mud piles mnemonic, which, as you know, is your absolute master key for remembering the causes of a high anion gap.
Moving to Case 5, Hepatic Encephalopathy, or the ammonia accumulation.
When a patient with a known history of liver disease presents with altered mental status, asterixis, which is that characteristic flapping tremor of the hands, and an elevated serum ammonia level, that clinical triad practically screams hepatic encephalopathy. We have to act fast and administer lactulose. This drug has such an elegant three-step mechanism. First, it acidifies the colon. Second, that newly acidic environment forces the toxic absorbable systemic ammonia, NH3, to convert into ammonium, NH4+. Because ammonium carries a positive charge, it can't cross back over into the bloodstream. And finally, step 3, it traps that toxic compound right there in the gut so it can be excreted safely in the stool.
Now, how do we actually know the dose is right? Well, the clinical goal of this pharmacological management isn't a specific blood test at all. It's a very practical bedside metric. We actively titrate the lactulose dose until the patient achieves exactly 2 to 3 soft stools per day. Once we consistently hit that target, we know we're effectively clearing the ammonia and reversing the encephalopathy.
And now we've reached our final file. Case 6, Acute Gout, the Crystal Crisis.
Our final patient presents with podagra, that classic red, swollen, and intensely tender big toe. But here is the catch we have to navigate. They absolutely cannot take NSAIDs due to a previous gastrointestinal bleed and an elevated creatinine level. So how do we treat this acute flare? Well, first, we must confirm the culprit. This acute inflammatory monoarthritis is caused by the deposition of monosodium urate crystals. If you extract fluid from that joint and put it under polarized light microscopy, those crystals have a very distinct signature. They look needle-shaped and are negatively birefringent, meaning they turn a bright, unmistakable yellow when aligned parallel to the light.
When it comes to the pharmacology here, students mix these up all the time, but the distinction is vital. Since our patient can't take NSAIDs, for this acute management, you must use colchicine. Colchicine works by inhibiting microtubules, which directly disrupts the microtubule network and completely halts neutrophil migration to the joint, stopping the inflammation in its tracks. On the flip side, xanthan oxidase inhibitors like allopurinol or febuxostat decrease uric acid production. They are strictly for chronic prevention. In fact, if you give them during an acute attack, they can rapidly alter serum urate levels and actually destabilize the crystals, which will worsen the acute flare. And before we wrap up, here's a bonus clue that connects our pharmacological dots across disciplines. Remember this vital interaction? Xanthine oxidase inhibitors, like allopurinol, are also incredibly useful in oncology to safely prevent tumor lysis syndrome during leukemia treatments. But they cause severe, potentially fatal toxicity if they're combined with a drug called 6-mercaptopurine. Why? Because 6-mercaptopurine requires that exact same enzyme, xanthine oxidase, to be broken down. If you inhibit the enzyme, the toxic drug builds up rapidly in the patient's system. It's an interaction you absolutely cannot miss.
And just like that, it wraps up our morning rounds. Every symptom, every lab value, and every imaging result is a clue linking microscopic pathophysiology directly to real-world patient outcomes. As we've seen today, the real key to solving these clinical mysteries is understanding the deep mechanisms at play. So keep your diagnostic skills sharp, never settle for just memorizing a list of symptoms, and leave absolutely no mechanism unexamined. So what biological clues will you look for to crack your next complex case? Keep learning, and I'll see you in the next explainer.